Hello everyone, thank you for joining us for our second Matilda webinar this year. It's great to have you all with us. My name is Katrina Pryor. I'm a postdoctoral research fellow here at the Matilda Centre and I'll be chairing today's session. I'd like to give a warm welcome to our three speakers for today. We've got Professor Cathy Mihalopoulos, Dr. Longley and Dr. Mary Lou Chatterton, and they're here from Deakin University. So before I introduce them properly, I thought I'd go over a couple of admin type things first that will be hopefully useful for you to know. So I wanted to let you know that today's session will be recorded. So both the recording and the slides will be available for you to download. I'll send a link through either today or tomorrow as soon as I can get those together. And then we'll also hold a question and answer session at the end of the presentation. So you should see there a little Q&A section on your dashboard, so feel free to type questions as we're going along for the three presenters to address at the end of the session. If you have a burning question and don't want to wait till the end of the presentation, feel free to do that, or you can also type those in as we go throughout the webinar or at the end as well. Okay, so for people who are joining us for the first time, I thought it would be good as well to give you a little overview of what the Matilda Centre is and the type of research that we do here. So we were actually established as a centre late last year. We were formerly known as PREMISE, or the Centre of Research Excellence in Mental Health and Substance Use. And along with our name change, we recently moved from the University of New South Wales to the University of Sydney. And at the Matilda Centre, we focus on conducting research to improve our understanding of mental health and substance use disorders. And we also develop and trial a range of different prevention, early intervention, treatment and translation programs for these disorders. So in order for us to do this, we work closely with a range of different services, schools and community groups. And this webinar series is a great way for us to foster these lines of communication. So this is a photo of the Matilda Centre team. This is a recent photo that was only taken last month, I believe. And you can see our director, Professor Marie Thiessen, circled in the yellow there. So Professor Thiessen is an NHMRC Principal Research Fellow, and she's director of the NHMRC Centre of Research Excellence in Prevention of Mental Illness and Substance Use, also known as PREMISE, as an easier way to remember that. She's a National Mental Health Commissioner and last year was awarded a Companion of the Order Australia for her huge contribution to Australia's health and medical research efforts in the field of mental health and substance use. So it's now my great pleasure to introduce our speakers for today. So we've got Professor Cathy Mihalopoulos, as I mentioned, Dr. Longley and Dr. Mary Lou Chatterton. So Professor Mihalopoulos is Chair and Head of Deakin Health Economics, and her research interests lie in the economic evaluation of mental health and psychosocial care within the Australian context. She currently leads a team of mental health economists who work across multiple projects, including clinical trials, priority setting projects, costing studies, outcome measurement studies, and modelled economic evaluations. So a huge range of different experience there, Cathy. Dr. Lee is a research fellow in Deakin Health Economics, so part of the Institute for Health Transformation. And he's currently working on different projects, including the cost effectiveness of prevention and treatment for eating disorders, cost effectiveness of telephone outreach for suicide prevention, and also cost effectiveness of mental health promotion and prevention, which is obviously very relevant for today's presentation. And then Dr. Chatterton is a Senior Research Fellow there with Dr. Lee, so at Deakin Health Economics as part of the Institute for Health Transformation. And she's undertaken economic analyses across a variety of clinical areas, including infectious diseases, neurology and mental health. And in her current role, she's responsible for the practical implementation and analysis of economic evaluations within clinical trials, as well as the development of economic models to estimate the cost effectiveness of mental health treatments and prevention interventions. So a massive thank you to the three of you for joining us today. We're very lucky to have you with us and I'm looking forward to your presentation. So I'll hand over to you now, Cathy.
Thank you, and thank you to the Matilda Centre for inviting us today to present a webinar. So around the cost effectiveness of, I suppose, prevention of mental disorders and substance use disorders. But before we launch into more technical aspects of, I suppose, work that you're all probably interested in hearing, we thought that it might be useful to actually provide a little bit of a scene setting and context as to the actual task of economics and what it does. So many people just think it's about costs and cost cutting, and it's absolutely not. So my role in the webinar today is to really take you through a little bit of the background, and then Mary Lou and Long will go through some more specific work around the cost effectiveness of different interventions and programs of work, and then really finishing on some really exciting work that we're now launching into in collaboration with the Matilda Centre. So economics is basically a discipline that's all about the best allocation of scarce societal resources. And I think this kind of diagram really, presents it nicely in that you allocate resources to something and then you get something of value out of it, which is that little tree growing. So what we have in health in particular is the tyranny of choice. And so this is one of my teaching diagrams that I very painstakingly put together. But basically it's an oldie but a goodie, but it shows us in a very nice way what is core to the economics way of thinking, or the economics problem really, which is around opportunity cost. And so this is an old slide, as I said, which I updated with some more modern diagrams. But basically it was sort of, what $75,000 or what $100,000 might buy us within, say, the context of health. So you could get one neonatal intensive care stay for a preterm baby. You might get 1.7 episodes of hospital dialysis, a few more coronary artery bypass surgeries, a few more hip replacements, but a lot of quit smoking courses. So if you've only got a limited budget, which we often do in health, then how do you decide how to spend that budget when you've got, a lot of choice available to you? So why is there now an increasing focus on economics in health and mental health care as well? And I think the reasons are the same regardless of whether you're looking at health or mental health care. Now, I've been working as a mental health economist since really the late 1990s, early 2000s, and I have to say, the work is growing and it's becoming a lot more important, and these are some of the reasons. The first is burden of disease studies. So we've got a lot to thank our colleagues in the WHO to begin with, and now in the AIHW here in Australia, the Institute of Health Metrics at the University of Washington, which have really showed through these burden of disease studies where outcomes have been expressed as disability adjusted life years, which are really a composite health outcome, if you like, of mortality, years of life lost, and morbidity in terms of, years of life lived with a disability. And those studies really showed strongly, a few years ago now, certainly in the early 2000s, the huge burden that's associated with mental disorders in particular. We have cost of illness studies as well, where again, these are descriptive studies that really show the massive cost that's associated with mental and substance use disorders. For example, the WHO has estimated that depression and anxiety cost $1 trillion per annum, which is massive. And a lot of that cost some of it is in the healthcare sector, but a lot of it is broader than the healthcare sector to do with losses in productivity. For example, people drop out of work because of poor mental health, but not only will they do they drop out of work in terms of absenteeism or not working at all, but also presenteeism, where people are at work and just not functioning optimally. So we have many studies both here in Australia and internationally showing huge cost of illness studies. Furthermore, we've got evidence of inefficiencies within the current system. Both our work and others, both here in Australia and internationally, have shown that we can probably do better with our current existing resources. But not only that, we probably need a few more resources to develop an optimal system where the right care is reaching the right people in the right dose, more importantly. And so hopefully through our Productivity Commission's inquiry now, and here in Victoria we've got the Royal Commission, I think some of this inefficiency will really come to bear. There's a perception also that health expenditure is too high and unsustainable. And in a way this is true, but I suppose as a health economist, there's no a priori kind of golden number that is the right amount that we should be spending on healthcare. Currently, I think we spend just over 9% of our gross domestic product on health. In the US, it's a lot higher than that. And there's no golden rule, I suppose, that says you should only spend this amount on healthcare and this amount on welfare or this amount on defence. In reality, if you're getting good value for any spend, it's probably worth doing. So I think that certainly from a government perspective, there is a perception that healthcare is very expensive and costs a lot, and that's it does, but if there's good value to be gained from that, I think it's probably not too bad. In terms of what we should be spending on healthcare, there's a great diagram that I've got that I'm not showing you today, but we're probably just above the OECD average in terms of what other comparable countries spend. So we're probably not too far off what we probably should be spending if you're looking at our other colleagues in the OECD. There's also business case requirements now, which I think is becoming more and more important, where new interventions, new models of care have to show that they're cost effective and are associated with a positive return on investment. And so this has really led to growth in the tools of economic evaluation, which is core business to certainly what we do here at Deakin Health Economics. So as I've said, we've got this basic economic problem of scarcity. Wants are unlimited, but resources are limited. I have no doubt that our health minister has to ward off a lot of people every day from all areas of health, mental health, cardiovascular disease, cancer, each arguing that their area is the most important and associated with a lot of burden, and it's costing too much and they can't afford to do anything. So, there's lots and lots of demands, but there are only limited resources. What is true, though, for mental health care is that commensurate with the burden of mental health, there is less of a spend in mental health compared to other areas of health. So this is true, even though we have had quite large increases, which are great, over the last few years in terms of public spending, not private, I'm not talking about private spending here, but public spending on mental health, the burden is still very large in comparison to that. We have an opportunity cost to every choice, which is exactly that diagram that I showed you before. By choosing to spend in a particular way, you can't spend in another way. So we have the tools of economic evaluation that really allow us to try and inform some of these decisions around where to spend in a very open, transparent and hopefully accountable way. The burden of disease studies that I discussed before and the cost of illness studies are really only descriptive. They just describe the burden that's associated with mental and other health problems. But it is really only through the use of the tools of economic evaluations, which is, and I've got there in red some key important things there. It's the comparative analysis of alternative courses of action, so comparing one intervention to another intervention or to treatment as usual in terms of both the costs and the consequences of outcomes or benefits of these alternative courses of actions in order to assist policy decisions and decision making. So a little bit about economic evaluation. As I said, it is an explicit technique of evaluating opportunity cost and value for money. Costs included in any economic evaluation will depend on the perspective. Usually in health and mental health, we tend to adopt what's called a health sector perspective, a societal perspective, which our theoretical economic textbooks tell us we should adopt, say that we should include all costs no matter to whom they accrue. So that would be both costs within the health and the mental health sector, but also to society in general. So costs that might fall on the private sector, the criminal justice sector, the welfare sector, community sector. And, importantly, things like productivity impacts you should include. So what we tend to do more so, or are doing, because as you can imagine, including all costs can become very cumbersome. And I know that myself and Long and Mary Lou have lots of robust debates with our collaborators, our clinical collaborators, where our resource use questionnaires are very, big, and they're very long, and they ask lots of things because we try and capture all these broader costs, and of course people then don't complete them because they get sick of asking them resource use questions. And so in reality, we have to make decisions around what are the key costs that are likely to be impacted by any economic or by any intervention. And what we also now include almost always are impacts on productivity, which are important to capture and certainly important to our decision makers. So that's the cost side, but equally important is the value side. So what do we mean by that, by value or consequences or benefits in our economic evaluation? So how we define value is equally, if not more important than how, we measure our costs as well. So in our, we have different techniques, and really in, under the umbrella of economic evaluation. And what really delineates those is how outcomes or value is measured. So in cost-benefit analysis or return to investment studies, it is often argued that these are better understood by policymakers because really the final output of of those kinds of studies is that for every dollar invested, we get X amounts of dollar back. So we get return on investment ratio, or sort of simple outputs of the studies like that. And often with those sorts of studies in cost-benefit analysis, more formally, all outcomes, including things that don't have an inherent dollar value, are given a dollar value. So a health outcome that might be, a point improvement on, for example, a depression scale, will be given a numeric value. In return to investment studies, it's hard to do that, and so they tend to take a more narrower focus. And what those studies tend to do is they look at more cost offsets that you might get by preventing, for example, a substance use disorder, a mental disorder. You get cost savings in terms of healthcare dollars that aren't then used, and then you might get some savings in productivity impacts. So that's what we tend to see in more narrower return to investment studies. Cost effectiveness analyses measure outcomes or value in more disease-specific symptoms or disease-specific symptom changes, so cost per point improvement on a Hamilton anxiety or depression scale, like that. And then cost utility analyses, which are kind of our preferred technique, measure outcomes in terms of a generic index of morbidity and mortality. I spoke before about disability adjusted life years, which have become quite prominent because of the burden of disease studies. What you more commonly see used, though, in the economic evaluation literature are quality adjusted life years, which are a similar metric to disability adjusted life years. But what a quality does as well, similarly to a Dolly, is that it weights the length of life by the quality of that life, therefore including within a single number impacts of any intervention on both mortality and quality of life. And why does all this matter? Because in an incremental cost effectiveness ratio, we've got the costs of any two interventions or programs of care being compared. Cost one, the cost of the second intervention being subtracted by the first, divided by the benefits. That could be defined in terms of, as I said before, QALYs or Dollies, or disease-specific outcomes. So how you choose to define outcomes is really important. How are funding decisions actually made? I think this is a really important question to just focus upon for a minute, because again, we often have discussions with our clinical collaborators, or and they will say to us, oh, why do we need to measure QALYs? Well, they're really important because that's actually the main outcome that's used by our formal health technology assessment agencies. For example, here in Australia, the PBAC, the Pharmaceutical Benefits Advisory Committee, and the Medical Services Advisory Committee make a lot of their value for money judgments, and they decide what gets up and what doesn't get up under those two funding streams. Looking at QALYs as outcomes there, and using cost utility analyses as the main form of economic evaluation technique used. And so there it's really important that we measure QALYs well. in other kind of, decision-making bodies. And unfortunately, as you all know, mental health is complicated. So we have drugs that are funded by PBAC. We have, services that might be provided under our NPS, so that will get evaluated under MSAC. So their qualities and cost utility analyses matter. But then we have a lot of our mental health care being provided outside of those two funding mechanisms, for example, by state governments or, local community health centres or those sorts of agencies. And there, I suppose, there are no strict rules around what economic evaluation technique gets used there. And there we tend to see return to investment analyses more commonly used or asked for. And of course, under those analyses, to kind of get the green light, what you need to show is that any intervention is in fact saving resources. Whereas under PBAC and MSAC, you don't need to show that they're saving resources, but rather that they're good value for money. And so what we have here are, different decision-making contexts that actually use different criteria and different judgments around what is value for money or not. So I want you to tuck that away for now, but it is one of my bugbears as, someone who's been working in this space a long time, but it kind of means that different interventions actually have higher hurdles that they have to jump through in order to kind of get funding. So I think that's an important issue for our system, and certainly one that I've put forward in a submission to the Productivity Commission and others. All right. So just to convince you a bit more, what are the benefits of using a generic outcome measure like a QALY in health and mental health? Well, I think this slide kind of helps to kind of contextualise this. If you are comparing two interventions, intervention A, intervention B, one's got low cost, one's got high cost, one's got no change in life expectancy, but a large improvement in quality of life. Intervention B has a modest improvement on both life expectancy and quality of life. So how do we decide, which of those two is funded? Well, a QALY or quality adjusted life year adjusts the length of life by the health related quality of life or the preference weight or a number that gives sort of some kind of evaluation of the quality of life. So health related quality of life or a preference weight, the way that these weights work are weights from 0 to 1 that are anchored on death to perfect health. And various domains of health related quality of life that comprise health are then given a weighting. So if you've got quite good quality of life and say just a minor decrement, say on you might have a little bit of pain, then your utility weight or your weight is likely to be up towards 1, or the perfect health state where you're perfectly healthy and there's no decrements at all in terms of your quality of life. If, for example, you've got severe pain, poor, you're quite depressed, you can't socialise, you've got quite a bad quality of life, then the quality of, on that 0 to 1 health state, it's likely to be more down the 0 end. And in fact, there are some health states that are valued as worse than death, and they're given quality of weights in the negative sphere. So how do we measure utility or quality of life? Again, very important. There are direct methods, which I actually won't discuss today because they're not commonly used, and certainly they add to the scale of projects and quite a lot, and they're quite expensive to do. And some of these direct methods are things called standard gamble, time trade-offs, discrete choice experiments. What we most frequently do in most of the studies, and certainly most of the economic evaluations that a lot of you may be familiar with, is that we use quality of life scales that have this added scoring algorithm that allow us to get a utility value from these quality of life scales, and they're called multi-attribute utility instruments. The most commonly used ones are the SF60, which is derived from the SF12 or the SF36, the Health Utilities Index suite of scales, the Assessment of Quality of Life suite of scales, and there's quite a few of those, the EQ5D, which many of you may be familiar with, commonly used because it was mandated in the UK that they all had to use it. Not so great for our low prevalence disorders, I should say that. In mental health. And then there's the CHU9D, Child Health Utilities Index, of which we use more frequently in children and adolescents. We also have other measures that are now emerging in the literature, such as the capabilities approach, which measures years of full capability. And it has been argued that capability may be a better measure for health than quality of life, but that really hasn't taken off in a widespread way right now, but just thought I might mention it today. you know, how do these quality of life scales work? They're very simple kind of scales, and then they're called, you know, patient-reported outcome measures as well, because then participants in the studies, you know, tick how they're feeling according to different scales. So this is the EQ5D 3-level scale, and this is the Child Health Utilities Index, which we're using, I think, in our climate school study that we're doing collaboratively with the Matilda Centre. So the kids will tick how they're feeling across these different dimensions. And then we add an extra scoring algorithm that allows us to give that 0 to 1 scale, and then we calculate, using, you know, statistical techniques, what the quality of life is with children who get an intervention versus those who don't get the intervention, according to the differences between those two groups in terms of their quality adjusted life years. Now, which scales should we use? That's a very vexed question, and one that I personally published in. So if we look at depression and anxiety, this is a study, and I won't go through this in some detail, but not all quality of life measures are the same, and it can actually make a big difference to your incremental cost effectiveness ratio. So I'm just putting this out there, in that often, you know, our clinical collaborators will come to us and say, let's use the EQ5D because it's only 5 questions and it's short and we've got all these other things to measure. Well, it actually can make a big difference to the final cost effectiveness of the study, depending on what scale you use. So please be aware of that. And sometimes the longer quality of life scales, which can be a bit more burdensome, are more nuanced in terms of, you know, the domains of quality of life that they pick up. And so at the very minimum, you do want to ensure that the scale that you use actually impact or measures the domains of quality of life that are likely to be impacted by any intervention. So certainly in mental health, where our interventions can impact broader things than just, say, depression and anxiety or pain that might be picked up by the EQ5D, things like self-esteem, you know, socialisation, you know, ability to undertake role, those sorts of things are actually measured by some questionnaires and not others. So it's important to consider which scale to use. Just a quick note on Dollies, because I think Dollies are really important, and this is some work that we've recently undertaken where we've used the new utility or the new disability weights for ADHD in some work that we did as part of a CRE with Harvey Whiteford and others. And because the new burden of disease disability weight for ADHD is so small, 0.013, teeny tiny, it means that the incremental cost effectiveness ratio of commonly used, for example, medications for ADHD are very, very high, $180,000 per Dolly averted. If you use the older disability weight or even poly weights for ADHD, you actually get much difference, you know, quite a large reduction in the incremental cost effectiveness ratio to $25,000 per Dolly. So again, very important that I think as a community we have an understanding of these weights and what they mean, because they can really impact the cost effectiveness ratios of different interventions. And this is a notable example coming from our more recent burden of disease weights. So with that, I might now move across to my colleague, Long, who'll take us through some more practical work, I think.
Thank you, Cathy. So now I'm moving to introduce you about the evidence of cost-effectiveness for intervention to prevent mental health problem in general. And then Marilu, my colleague, will go through with you the evidence in substance use disorder area. So our team already do a review for economic evaluation of intervention to prevent mental disorder and public in 2015. We now update the literature and will be very soon to publish another new evidence in economic evaluation in this year. So mode of evidence for economic evaluation in Australia come from 3 big work. The first one from assessing cost effectiveness in prevention. This project include, you know, many intervention for prevention, even, you know, and include mental health in one key area. We are also assessing cost effectiveness in mental health for both prevention and treatment. And recently, we had a work from the Center for Research Excellence in Mental Health System Improvement, would include further other mental disorder, including eating disorder. So I will introduce you some intervention that found very cost-effective in Australia, also internationally. So the psychological intervention, including CBT, very cost-effective for prevention of anxiety in children, adolescents, or youth. School-based psychological intervention for the prevention of the depression is also cost-effective in children as well. Social and emotional learning intervention were found very cost-effective for prevention of bullying or conduct disorder in children and adolescents. In adults, we found that psychological intervention for the prevention of depression is very cost-effective, and psychological intervention for the prevention of postnatal depression in adults as well. We found e-health in workplace setting for mental health prevention, especially for depression and anxiety, are very cost-saving. And for older adults, we found that internet-based CBT is very cost-effective for prevention of depression or loneliness in the older adults. So I will hand over to Marilu, my colleague, to talk about the evidence in substance use disorder.
Great. Hi, everyone. I'm just going to pick up where Long left off, and we're kind of at the start of looking at the cost effectiveness of substance use prevention within some of the work that we're doing. But there is a body of literature in this area already that's existing. And what we found so far, and this isn't necessarily comprehensive review, but this is the start of our review of economic evaluations to prevent substance use. And what we found is that much of the literature in this area is actually from the United States. And the technique that's primarily been used are cost-benefit analyses or return on investment studies. And what's primarily been found is that substance use prevention programs, and there's been a wide range of them, but overall, they appear to have good return on investment. And they range from return on investment figures of roughly $5. So for every dollar invested in a prevention program, that program can return $5 back to society. And at the high end of the scale, there's been some programs that have been shown to return upwards of $100 per dollar invested. Now, the reason there's such a wide range is because of what's been included in these return on investment studies. Some are more narrowly focused on primarily sort of the healthcare sector, or some may just include focus on healthcare and productivity, as Cathy has mentioned previously. Others can look very broadly and look at a wide range of societal outcomes, everything from criminal justice costs and housing costs and educational outcomes as well. So some of these studies, they really cover a wide range of cost outcomes, and that's why we see this wide range of return on investment figures. There was also another program in the UK, and this was actually this particular analysis by Jones. They did a cost effectiveness analysis. So rather than looking at the cost of the program and then looking at the benefit of the program in dollars, as these other studies based in the US looking at return on investment, what they did was they looked at the cost to prevent one additional case of hazardous or harmful drinking. So this is a traditional this is traditional cost effectiveness analysis, where your outcome measure is in sort of what we call natural units. So, and in this case, it's avoiding a case of hazardous or harmful drinking. But nonetheless, in this particular analysis, they did show that their particular program was actually rather cost effective. It was £257 to prevent one additional case of hazardous or harmful drinking. So the problem with cost effectiveness analyses is it's somewhat difficult to quantify that outcome. I suppose inherently we all can look at, you know, an individual that is engaging in harmful drinking and think about what the cost would be to that, you know, so the cost of people ending up in emergency room, or, you know, longer term harmful drinking having ill consequence or poor health consequences, such as, you know, cirrhosis and liver failure and those types of things. So we can kind of monetize that in our own head, and that's not necessarily explicit. So you can kind of see, I guess, across the literature that we have here, I guess how cost effectiveness analysis is a bit different from cost benefit analysis, and how, you know, using outcomes in those natural units, you know, can be problematic in terms of having sort of an explicit value for money threshold. Now, we're actually, as I mentioned, we're sort of at the beginning of some of the work we're doing in the substance use area, and we are looking forward to adding quite a bit to the evidence base. We're currently doing a within trial economic evaluation. Much of the work in the substance use area and all of the work that I've described previously, that was all done through economic modeling. So we essentially take a variety of parameters and put them together in, you know, a decision analytic model in a sort of a conceptual framework to come up with costs and effects looking at an entire population. We're actually able to collaborate with our colleagues at the Matilda Centre as part of a trial called the Climate Schools Combined Trial, and we're able to undertake a what we call a within trial economic evaluation that's going to be looking at programs, the Climate Schools program to prevent mental health problems, also to prevent substance use. They have different modules, and within that trial, it was a 4-arm randomized trial. So we're really excited about looking at the cost effectiveness and the cost utility. So we're going to be looking at cost per quality adjusted life year within the Climate Schools Combined trial setting. So that will certainly provide some very useful evidence of the effectiveness of prevention programs within a school-based setting and within Australia. So we'll have some good homegrown evidence there. The other thing that we're currently undertaking is a systematic review of economic evaluations of interventions to prevent substance use. So what I presented previously was a bit of just an overview of what we found to date, but this systematic review will be comprehensive and look at all of the literature and you know, provide again a good evidence base of the evaluations that have been shown to be good value for money within this prevention space. And then as well, we're also looking forward to collaborating with our colleagues in the Matilda Centre on additional trial-based and modeled economic evaluations within the PREMISE program, the CRE, the Prevention and Early Intervention in Mental Illness and Substance Use Centers for Research Excellence. So we actually have a large body of work that we're putting together with our colleagues at the Matilda Centre. So I guess the message for that is to watch this space. And if you can go on to the next slide, yes. So we have you might want to follow us at our Twitter handle, which is @DHEDeacon. And I'll just kind of wrap up the proceedings today with a picture of our lovely mental health economics team, which is part of our larger Deacon Health Economics unit, which is about 35 strong at the moment. So thank you, everybody, and we're quite happy to take any questions you may have at this point.
Wonderful. Thank you, Mary Lou. Thank you also, Cathy and Long. I have been eagerly awaiting some questions that have come through during your presentation, so I thought I would kick off with one that came through that I thought you would have a great response to, and that's very relevant to some of the work we do here at the Matilda Centre in terms of internet delivered interventions. So someone asked, given that internet-based interventions are inexpensive to deliver, can't we just assume they're cost effective because of that?
Mary Lou, I'm going to hand over to you for that one, because that's one that you've spent a bit of time thinking about.
Great, thanks, Cathy. Yeah, it's interesting, just because, yeah, so everybody kind of assumes that because internet delivered interventions and apps are very inexpensive to use, and for most of us, we don't pay anything to access these services, that they don't have any cost associated with them, and therefore, well, they must be cost effective. The problem is that there is actually a fair amount of cost. There's an opportunity cost to develop these internet platforms and apps. So there's quite a bit of resource that goes into that development. So they aren't necessarily free from a societal standpoint, and there are actually rather large development costs. And we've been doing a bit of work in this space, and we know just how costly it is to develop an app. So yeah, so we can't just assume. We need to do good empirical research and evaluate the costs and outcomes from these programs.
Exactly, thank you. That's a great response. I was also interested in someone else's question that's come through. So someone asked if there's someone who wants to look at the cost effectiveness of an intervention that they're running, do they need a health economist on the team, or can they do it themselves? How simple is it?
That's one for Cathy, I think.
I think there's no doubt that you should involve a health economist from the beginning. So the techniques are, I mean, what we did today was we tried to explain things in a fairly simple way, but they're not simple often, and our techniques are often not straightforward, and there's specialisation in the skills that are required. So I think not because I'm trying to drum up work for our unit, but I think like anything, the quality of the work reflects, who's been involved. So I think now the thinking is that, like any good project, you should involve a statistician probably from the beginning, as well as a health economist, certainly for what I would deem trial-based economic evaluations. So, yeah, look, there is a perception that there's a real shortage of health economists, and there aren't many around, but there are some pretty big groups, around the country. So certainly, there's a few here in Australia. I think every main university has a health economics group, and the same in New South Wales, Queensland. I don't think there's a state where there's no health economists. So, occasionally you might just kind of reach out to one and they'll say, oh, I'm too busy, but then hopefully they'll, refer you to someone else, and then you'll land upon someone that will help you. But I know that we, for example, collaborate with a lot of different teams across many, many different, not only universities, but outside of the university sector as well. Specifically within mental health. But look, as we said at the beginning, I'm the head of Deakin Health Economics, and we've got a really large program of work around obesity prevention, both the prevention and treatment of non-communicable disease, oral health, and, now doing a lot more work in ageing, healthy ageing and disability as well. So there are, and we've got 35 health economists that comprise our unit. I know Share in New South Wales, for example, is quite large as well. So definitely talk to your friendly neighbourhood health economist, I'd say.
Yes, I agree. I think there's things that are overlooked as someone who doesn't necessarily completely understand what is involved, knowing, like you mentioned, what measures could be looked at or questions to include if that's part of something you want to do in a project. So that's really important.
Yep.
And another question we have is whether governments use the results of economic evaluations when making funding decisions in mental health services.
Ooh, that's a vexed one. Sometimes. That's the bane of my life. look, you would hope so, but like a lot of things, I think, you know, that slide that I put up, where informal, what I would say formal kind of, you know, health technology assessment driven funding mechanisms of what we've got, which we've got two in our country, which is PBAC, PBAC drugs, and MSAC, Medicare, yes. So I think that's, you know, they're two areas where the results of economic evaluation really matter, and they count, and they are very firmly taken into account when funding decisions are made. And I should also declare that I sit on the economic subcommittee of the Pharmaceutical Benefits Advisory Committee. So that economic subcommittee really scours through the submissions that are made by pharmaceutical companies. We prepare very formal advice that we then give to the PBAC, upon which they base their decision making on. So yes, there are some areas where the tools of economic evaluation are absolutely used. In other areas where there's not this kind of formal requirement, I think the extent to, you know, to which it gets used is, in all honesty, sadly variable. I think there are, you know, it's really great that the Matilda Centre is taking, you know, the potential outputs of economics into account, and working with us to produce what I would hope to be very high quality evidence, because there is a lot of economic evidence out there that maybe isn't as rigorous. And so, you know, we welcome that. But I think, you know, at the end of the day, you know, governments will use whatever evidence is available to them. They don't read often the peer-reviewed academic literature, that they'll just pick up whatever report or something, if they do that at all. And so I think we, as an academic community, also need to become better at, you know, informing governments of the results of our work. How many times, I'm sure, you know, many of you who are sitting out there have heard announcements of new interventions that will get, you know, supported, and you think, oh, okay, where's the evidence for that in terms of effectiveness and cost effectiveness? So I think, you know, we need to do it a lot better in terms of getting the results of our studies out there in terms of translation and impact. So the short answer to that question is sometimes they get used. In some areas they absolutely get used, and in other areas not so much, or to a varying degree.
Well, let's hope it continues and that more and more people recognise it for the importance that it has. We know how valuable it's been for our studies here at Matilda Centre. So it's.
I think, you know, also Katrina, and, you know, I mean, it's, yes, it's important that our studies get used, but I also think, you know, it's important that, you know, all of us as taxpayers actually demand value for money from our healthcare systems. And so, you know, we just want to make, like me as a taxpayer, putting aside I'm taking off my academics hat now and putting on my, you know, taxpayer's hat. You know, you want to ensure that what is provided works and is good value for money, because of, you know, that diagram. You know, and what we're doing is we're instilling in our decision makers that faith that what, you know, the healthcare that we're getting, whether it's in prevention or, you know, treatment or wherever it sits, is actually good value for money, and that, you know, if you can do better, that we will do better. And we can only answer those questions through rigorous research. So, you know, I think it's imperative. I mean, I want to make sure that, and I went into health economics in order to try and inform really important decisions around good use of limited healthcare resources. So I think we all need to demand that.
Yeah, exactly. Thanks, Cathy. I've got two more questions that I thought I'd ask before we wrap things up. So we've got someone here who said, as a grandmother caring substantially for her 2-year-old granddaughter due to combined mental health and substance use issues with her parents, I wonder if costs are recognised within any of those models.
Oh, yes, that's such an important question. And carers' costs is one that actually we think about a lot and have been not ignored, but they're difficult to put. It's difficult to put a dollar value on those sorts of costs, because here we've got a grandmother who is doing a really important job, and of course there's an opportunity cost to that time, which needs to be considered. Now, if she wasn't able to look after her granddaughter, then someone else would have to do that, wouldn't they? Because of these, or there might be other consequences to that. So there is no doubt that the cost of carers and the benefit that carers also provide be considered in our studies. Unfortunately, our methods aren't quite up to what we know should be done. So certainly there's work that we're doing here at Deakin, and I know other universities around the country are doing this as well, to provide methodology and ways of actually capturing the costs and benefits of caring in a much more holistic way compared to the way that we've done it before, because I think we are really undervaluing. So we're doing two things. By ignoring the cost of carers, it often looks like, you know, interventions are a lot cheaper than what they really are, because, you know, costs are actually shifted elsewhere, you know, and they become like hidden costs, and it's important that we consider those, but also the benefits aren't properly realised as well. So often, you know, if you do get you know, good, effective mental health care, then the benefits are not only to the individual, but they're broader, aren't they? So there'd be, you know, the broader benefit to the grandmother there that we had that great question from, but also the child, the 2-year-old child that's now got, you know, their parent there that's able to look after them. So there's cost, but there's also many benefits that aren't being appropriately captured in our studies because we've still got some limitations of our methods. So I think that was such a great question and a really important question, and one that what we do now is we tend to describe those sorts of impacts, but they're not really well captured in the maths of our analyses. So I think we've got to do a much better job of capturing them in the maths of our analyses rather than just in a descriptive way, which is what we're doing now.
Yeah, great question, wasn't it?
Yeah.
And one final one is just someone's asked whether art therapy has been researched as an intervention that could be used as a preventative measure for prevention of substance use problems.
Because I mean, I'm not sure. I'd have to have a look at the literature. It's not something that I don't think, are we? We're not.
Kathy, yeah. So I mean, so far I haven't come across art therapy as a preventive intervention for substance use. It may show up in our systematic review, but I haven't really seen it yet. Long, have you come across anything?
No, I haven't seen it yet, so just wait.
Yeah.
Yeah. It's interesting because we've done some recent work looking at the area of sort of social isolation, and I know that different art programs have been used in that particular area to sort of get people out and about and interacting. So we have seen some economic evaluations of different sort of art programs in that context, but not necessarily for substance use.
Yeah.
Interesting. Well, thank you. A big thank you to the three of you for presenting for us today and talking about your work and how that ties into us here at the Matilda Centre and with the PREMISE Centre. And thank you to everyone who joined in. We really appreciate your attendance. So we will be holding more webinars throughout the year. So I encourage you to sign up to our mailing list to get updates about those future webinars. But otherwise, I will be sending a link to everyone who registered for today's webinar, which will contain both the recording as well as the slides from our three presenters today. But yes, thank you very much for attending, and I hope you all have a great day. Thanks again, Cathy, Long and Mary Lou.
Bye, everyone.
Thank you.